So this is the story of a 65-year-old female. She came with visual loss in her right eye. And the fundus exam, even though the image is not really clear, there was a PD in the fovea and subretinal blood. So we performed a fluorescent angiography that showed early hyperfluorescence in the macula and late leakage. Then we proceed with ICGA that showed a well-evident vascular network in the early phases, and then an hyperfluorescent plaque in the late images. The OCT confirmed the presence of an active neovascular membrane in the fovea. There was indeed a fibrovascular PD. There was a well-defined shram, so subretinal hyperreflective material, and there was also subretinal fluid. The patient was treated with anti-VEGF, but despite the treatment, she developed a massive fibrosis in the posterior pole, and then the visual acuity was very poor at the end, so was counting fingers. So the development of fibrosis is not specific of age-related macular degeneration, but is a common and end-stage disease of different neovascular diseases. Also in rarer form of macular neovascularization as those associated with pachychoroid disease, myopic neovascularization, or inflammatory macular neovascularization. So the goal of the presentation today is to review the pathogenesis and the molecular pathways of fibrosis, to review the incidence and risk factor, and summarize the preventive strategies. So let's start with the first point. So the fibrosis is actually an exaggerating wound healing response. And it's not only specific of the retina, but is found very similar in other organs of the body, such as the liver, the lung, or the skin. And there are two main events that happen. The first one is called epithelial to mesenchymal translation. So we have epithelial cells, in this case retinal epithelial cells, that get damaged, for example, from macular neovascularization. They lose their contact with the basal membrane, and they have a conversion in fibroblasts and myofibroblasts and start to migrate into the retina and produce collagen and other extracellular matrix proteins. The other second important event is the angiofibrotic switch. And this is particularly important in the retina where we have macular neovascularization, where also endothelial cells from the macular neovascularization starts to produce collagen and contribute to extracellular matrix deposition and finally, eventually, fibrosis. So this is a list of all the cytokines and growth factors that have been extensively explored. These are of interest because each of them can potentially become a therapeutic target to combine with anti-VEGF in order to limit and reduce the risk of fibrosis. But unfortunately, none of them has ended up with a satisfactory results in clinical trials. This is one of the most recent. It was published in 2020. It was an attempt to combine aflibercept with antiplatelet-derived growth factor, but the authors concluded that at the end of the trial, there was no advantage to combine the two drugs, and they were not superior to intravitreal aflibercept alone. So let's move now to the more clinical point of view and review the incidence and the risk factor. It's very hard to combine all the studies about the prevalence of fibrosis because they are very heterogeneous. And mainly this heterogeneity comes from different study population, for example, randomized clinical trial or real-life experience, but also on the modality where we grade fibrosis. So at the beginning, for example, in the CAT trial, there was only color fundus photography that was used to diagnose fibrosis, but now we have OCT and also polarized light OCT that are more efficient to diagnose fibrosis, and this may have an effect on the total prevalence. But most importantly now, we have the long long-term result, so we can estimate the incidence of fibrosis. And this is a very nice study that was published recently in the American Journal of Ophthalmology, and these are Italian data about 2 tertiary referral centers, and what we can see that in 10 years, the incidence, the cumulative incidence of fibrosis is over 50%. This means that in 10 years, 60% of the patient that starts anti-VEGF treatment for AMD ended up having fibrosis and ended up having poor visual outcomes. Let's review the risk factor. So most of the data comes again from the CAT trials, where it was evident, it was clear that type 2 neovascularization and the presence of subretinal or intraretinal hemorrhages was associated with an increased risk of fibrosis. But there are also some clinical studies. For example, this very nice study was recently published by one of our colleagues that analyzed the presence of SRAM, so subretinal hyperreflective material, and he found that a well-defined SRAM may be associated with type 2 neovascularization was a higher risk to develop fibrosis compared to ill-defined SRAM that nicely regresses after anti-VEGF. We also tried to contribute to estimate the incidence of fibrosis, so we collected cases. This was a multicenter study where the patient came in the active phase with a bacillary detachment, so a detachment of the photoreceptor where the myoid and the ellipsoid remain attached to the retinal pigment epithelium, and the external limiting membrane instead detaches. And we found that in this particular case of patients, the incidence of fibrosis was much higher. It was as high as 75% at 4 years. But again, we used our experience with large clinical experience that we have in our center, also to estimate the incidence of fibrosis in other diseases, not only in AMD. These are cases of, this is the data from more than 300 eyes with myopic neovascularization, and we found that yes, also this eye can have fibrosis despite treatment, even though the incidence was lower at 5 years, it was 34%, that is lower than AMD, but interestingly, this patient started from a worse logomar visual acuity, that is a green line. Maybe this suggests a more aggressive or a larger CNV as compared to patients that did not develop fibrosis. And also they had a steeper loss of vision over time, while the other patients instead maintained their vision over more than 5 years. And we did the same also for another rare type of disease. This is macular neovascularization associated with the angioid streaks. This was again a multi-center collection of data. And we have the other example. This was much more aggressive than AMD. So at 2 years, more than half of the patients developed fibrosis after just 2 years of follow-up. And as you can see in the line on the right, the red line, that is the eyes that developed fibrosis, they started from worse vision, but the other eyes catch the other eyes very, very early. And this may be due to also the high risk of atrophy in eyes with angioid streaks and macular neovascularization. Now let's move to the third part of the talk, and how can we prevent fibrosis since we do not have any effective treatment? So there are not many studies that have investigative preventive strategies. Most of the data are from the CAT and the IVAN trials, but also from a real-life UK pool of patients. And what we know that one of the major clinical risk factors for developing fibrosis is a higher degree of macular thickness fluctuations. So patient in the 4th quartile, that means that it is not a well-controlled macular neovascularization, had a double risk of developing fibrosis over the follow-up. And also this translated with a higher risk of losing vision during the treatment. So fibrosis fluctuation means visual loss over time. So in conclusion, the take-home message from this presentation is that we do not have still yet preventive treatment for fibrosis. This is still an important unmet need in medical retina. We can identify biomarkers and risk factors, so in order to anticipate the prognosis to the patient, maybe select the patient for future trials, and early treatment and very proactive strategies are much more effective in preventing fibrosis. And I thank again people for the invitation and you for attention.
It's absolutely important as a concept that fluctuation means decrease of the vision. So we must avoid any type of fluctuation.
It's true, and it was well studied in AMD, where more fluctuations were associated not only with fibrosis, but also with macular atrophy. And then the same study was replicated in other vascular diseases, for example, retinal vein occlusion and DME, and the conclusions were very similar, that higher fluctuations were associated with higher risk of visual loss. So maybe it's the stretching of Muller cells or the presence of fluid, chronic fluid. It ended up having higher degree of retinal damage.
Sure.
So it's very important.
And if you begin to study fibrosis, you meet immediately the mesenchymal transformation. And as Sandro said, this endothelial mesenchymal transformation, basic, is also reversible.
Absolutely. Yeah, absolutely. There are several two mesenchymal transitions during the formation of the lemma. It was endothelial monocyte macrophages, endothelial monocyte macrophages, epithelial cells go to mesenchymal phenotype. So it's not only one mechanism. There are several mechanisms that include several different types of cells that may move to mesenchymal transition and then to myofibroblasts. That are the real new cells that appear in the nerve membrane. There are also the basement membrane components that are secreted in a high quantity. So the point is that for sure the mesenchymal transition is one of the key points for the formation of neovascular membrane.
Thank you for the explanation.
Just a comment on the slide in which you show all the putative target. The point is that are all mediators, intracellular mediators, of course, of extracellular signals. And these mediators are activated not only specifically by one way of signals, but are the convergence point of several external stimuli. And if you try to block one of these, the problem is that you can have a huge effect of the side effects, a huge amount of side effects. So I think that it's real difficult to block
only one.
R1, R2, MMP, so the internal signal transductors.
There is a question. Thank you so much. There is a question, I think.
Are you aware if vessel maturation that we were just talking about, does it precede the formation of fibrosis or no? So my idea is, are there patterns on angioid CT, for example, that we could see that would identify increased risk for fibrosis?
So I'm not aware about a risk factor in the structure of neovascularization, but it's clear that when the neovascularization lose their more peripheral branches and it becomes a very a dead tree, it is a lower risk of fibrosis because it's maybe less cytokine. You are able to reduce the load of cytokines that stimulate fibrosis. So basically, if you try to transform your pruning neovascularization to a dead tree, then I think this is a good sign because the neovascularization shrinks and is less active.